I would like to, at the onset, I would like to actually thank the organizers, the NCRM, for giving me this opportunity to speak. I bring greetings from Parkinson's Disease and Movement Disorder Research Center at City Neuro Center. We also have an organization in India, which is Parkinson's Research Alliance of India. So I will just, sorry, I don't know whether I'm able to. Yeah, so can you see it as a screen?
Yes, ma'am.
Sure. Okay, so I will just briefly talk about the disease, the pathogenesis, and the treatment that's available currently. So we know these two major people who have had Parkinson's disease. One of them has a punch drunk syndrome, who had a repeated injuries and then had a Parkinsonism. And we know Michael J. Fox because he's been funding the highest amount of research which is going on in Parkinson's disease. So and Michael J. Fox actually epitomizes the young onset Parkinson's disease, having the Parkinson's disease at a very young age. So James Parkinson in 1817 had published this article on when he had looked at 6 patients with Parkinson's disease, and from that time onwards, a lot of research has been going on in Parkinson's disease. If you look at the epidemiology and the prevalence rates, you can see that the Americas have got the highest prevalence. Probably because they are assessing the prevalence rate. It amounts to almost 170 to 180 patients per 100,000 people. If you look at India, we've had small studies which has been done in India, which has shown a prevalence ranging from around 50 to 300 per 100,000 prevalence. If you look at people who are older than 60, it may come to around 308, or that is around 3 per 100 people, or going above 1%. So the latest epidemiological survey was done by Soham Desai from Gujarat, and he found that it was around 42%. This is the last one that you can see there, and that's the prevalence study. But these are all small groups. We don't have a generalized India-based survey, but hopefully with PRI we can have a generalized India-based survey. We know the etiology has been very well described, but it's a complex interaction of genetic and environmental factors. 20% of the Parkinson's disease patients have family history. 5 to 10% have very clear monogenic forms. We still are not able to correlate with what happens in monogenic forms to what happens in non-familial Parkinson's disease. There are a lot of genes which have come up. Glucocerebrosidase has become one of the assessment protocol for most of the treatment performers. NRK2 is one of the commonest non-familial Parkinson's disease because they appear late in the age process. So you have monogenic forms and also you have susceptibility genes. So we're looking at both of them. So we have a project which is going on in young onset Parkinson's disease in patients in India, which is called as Gopi YOPD, which has got like around 20 centers, and this is in collaboration with MedGenome, where we are like trying to look at the whole exome sequencing, whole genome sequencing to see what are the monogenic forms. There's also a Michael J. Fox Foundation led study, which is looking at genome-wide association study, the first one of its kind in India, which is being run by Sri Chitranan Institute with multiple centers again across India, where there have been 4 nodal centers and multiple smaller centers. We were one of the nodal centers, NIMS. We've just shifted around 6 months back, but that was so we are looking at. The idea is to collect 10,000 patients with Parkinson's disease and see what are the probable susceptibility genes. We are quite behind from the Western population in that sense, but we hope to catch up. And at least with this research grant, we are trying to look at the genome-wide association study. Also, we are trying to look at other Parkinson plus syndromes in the future. So what do you think are the risk and the beneficial factors? The risk factors which have been definitely shown are head trauma. There is a bit of a controversy about pesticide exposure, well water, metals, manganese, and iron. But head trauma has been found to be really caused as a risk factor. The protective factor, again, smoking has the highest protective factor, but I wouldn't advise anybody to start smoking at this point because smoking can lead to other problems, and I think Parkinson's disease is the least of the problems in that. Caffeine, non-steroidal anti-inflammatory drugs, calcium channel blocker, alcohol, all of them can have been shown to have some protective effect. Pathology has been very well described by Dr. Mulidhar before. So there's an accumulation of alpha-synuclein. We don't know how the alpha-synuclein comes in. The prion theory seems to be holding good currently, but it leads to formation of Lewy bodies in neurons. Again, this is not uniform. There are some genetic forms of Parkinson's disease where you don't have Lewy bodies at all. But what we know is that there's a loss of dopaminergic neurons in the substantia nigra pars reticularis, and this leads to the motor symptoms. But it's not limited only to the dopaminergic neurons. There are other neurons which are also affected, like noradrenergic, the serotonergic, the adrenergic neurons, which causes various other symptoms in patients with Parkinson's disease. How does it progress? Brackenbach had actually put a very nice hypothesis where it's supposed to start in the dorsal part of the pons and go up. But again, this has got a lot of its variation right now. People are not sure that this is the same thing as, I mean, this is applicable to everyone. So right now there are two types of progression that are considered. One is the brain first disorders and the body first. So some of the, I mean, patients seem to get Lewy body or alpha-synuclein starting in the gut, or and which is supposed to progress upwards. So that is the body first. And some of them start to develop in probably in the olfactory groove, and then suddenly start in the dorsal midbrain and go up and down. So the difference between them is that the brain first seem to have an asymmetrical onset, whereas the body first seems to have a symmetrical onset. So there's some variations, but we still are not sure what exactly is true, because the, I mean, to assess them becomes a little difficult. What are the clinical features? The diagnosis is made on motor features. So the clinical features are tremor, rigidity, akinesia, bradykinesia, postural instability, fixed posture, gait abnormality. I hope this please. Yeah, this is a typical patient who's got a young onset Parkinson's disease. You can see that she's emaciated. This happens later in the disease process, where they have feeding difficulty and gut immobility issues, but also because of the extreme amount of energy that is utilized by the tremor or the dyskinesias that they have and the rigidity that they have. So this patient has got a rest tremor. You can see that the tremor comes down when she initially starts to move, though it also starts to happen in the movement during the later stage of the disease. And you have rigidity, which can manifest as pain and stiffness. Leg wheel, cogwheel rigidity can happen. Sometimes you can have fixed deformities like this hand, where you can see that there can be deformities in the hand, in the toe, and that can cause some marked morbidity because they find it very difficult to walk or use their hand or their foot. Akinesia or bradykinesia is slowness of all activities. They have mass species, which is also part of the slowness of all activities, where they are not able to emote. They have decreased voice. They have decreased frequency of blinking. Drooling of saliva is also is considered to be secondary to the bradykinesia, where they're not able to swallow frequently. There's a decreased arm swing when walking. Handwriting comes down in its size. So you can see that typically this is a typical example of a handwriting which changes. So if you say that this is the start initial part where the letters are more bigger, it comes down at its sides as the line progresses. The typical Parkinsonian handwriting. Postural instability happens. They have stoop posture. They can have camptochomia, which is complete flexure of their trunk. They can have loss of postural reflexes, which has a tendency to fall. I mean, what we mean by postural reflexes is that suppose you're falling, you have these protective reflexes. You try to hold on to an object. You try to take a support of the wall. So these kind of reflexes also come down in the later stage of the disease, and they tend to fall, and so they have major injuries. They can have difficulty in raising from a chair. They can have difficulty in turning in bed, which is actually a feature of the bradykinesia. Again, because of slowness of movement, they are not able to turn in the bed. So this is another video where we're actually assessing a patient. So you can see that he is slow. He's got a tremor which is there in both hands. Tremor need not be present in all patients. So tremor predominant Parkinson's disease occurs in around 40 to 50% of the patient. You can have a bradykinetic rigid patient. So you can see that there's a postural instability. He's pulling him. He's not able to stand by his own. So he takes 3 or 4 steps, and if the other doctor was not there behind him, he would have fallen. So this is a classical example where you can see that he had a stoop posture, mask-like faces, tremor which was present, and postural instability. Gait disturbances can be different, and this start usually around 3 to 4 years after the disease onset. They can have a slow, short stride shuffling gait with reduced arm swing. Freezing, which can happen, means that they can have sudden stops. They just can't move. So the freezing can happen when they start to walk, or when they are walking, or when they are turning. These patients can have something called as kinesia paradoxica, where they suddenly can move and rise and move during emotional period. So if there's a dangerous period, they can suddenly seem to get the energy to run. They can also, most of the Parkinson's disease patients can cross obstacles much more easier than they can walk on a normal floor. They can climb stairs much more easier than they can walk on a normal floor. They can also cycle, which is actually a very important issue that they can actually cycle, and they find that much easier than walking on a normal route. Fascination is something different. So they have both these both these phenomena. We still don't know exact pathophysiology of why freezing occurs and why fascination occurs. Fascination happens when they start to move faster. So it looks like as if they're chasing their center of gravity. A lot of patients have to actually fall down to stop their movement. This has happened to quite a few of my patients where they say that they were just walking down and they started to walk so fast. They were reaching the main road and they just fell down on their own purposefully just to stop walking. So this is fascination. So let me again see. I'm sorry, there's a little lag in the. So this is the patient who's got a market freezing. You can see that he wants to turn, but he's unable to turn. So he's taking a long time to just lift his foot. It's like the feet are both stuck to the ground. He feels as if that it is stuck to the ground. If somebody puts a obstacle in front of him, probably a stick in front of him, he would be it would be very easy for him to cross. So now that the freezing has stopped, he's able to walk. What are the non-motor symptoms? These are all motor symptoms. So there's a whole iceberg of, a hidden area of non-motor symptoms where they can be divided into four groups: neuropsychiatric, where they can have cognitive impairment, depression, hallucinations and delusion. Anxiety and depression can start much earlier before even the motor symptoms can start. Autonomic disturbances, that is gastrointestinal disturbance, they can have constipation, cyanoria. You can see this patient who's got a very severe sweating abnormality, he's drenched in sweat. This was in winter, it was not in summer, and this can happen in their off state when the medicine is not working. So this is excessive sweating. They can have orthostatic hypotension. People can have sudden drops in blood pressure when they get up and they can fall. They can have sleep disturbances, REM behavioral sleep disturbances, which means that they enact their dream. So they start to shout or they start to move or they start to hit somebody. Sometimes they can fall out of the bed just because of the movement that they do. There's something called as restless leg syndrome where they feel a lot of discomfort in their foot when they are lying down, especially in the evening, and this means that they have to continuously move their limb. They can have insomnia, excessive daytime somnolence. These are all sleep disturbances which can happen. Sensory, they can have loss of olfaction. Pain can be a major part when they have stiffness and rigidity, and sensory fluctuations can happen. Now, if the patient has got a restless RE and sleep behavioral disorder and constipation and olfaction, there's a 90%. These are the typical premotor symptoms which can happen in Parkinson's disease. And if they have a triad of these three symptoms, they have a likelihood that they are going to turn into Parkinson's disease by around 90%. So 90% of them, if they have the combination of constipation, RBD, and loss of olfaction, they can have Parkinson's disease. How do you diagnose PD? The diagnosis of PD is by the actually pathological diagnosis. PET scan definitely help us to find out the level of PD. Now with the PET scans, most of the times we can identify Parkinson's disease to a major level. So these are two types of PET scans that can be seen. So this is called as an F-TOPA PET scan, where you can look at the caudate and the putamen, and if you have a dorsal, there is a ventrodorsal gradient, that is the posterior part of the putamen is more involved compared to the anterior part of the putamen, then you know that the patient probably has got Parkinson's disease. There is a reduction in the DOPA uptake in both the basal ganglia. Now there's a problem with this F-TOPA PET is that initial period they may actually have an increased amount of F-TOPA. There's another test which is called as a DAT scan, when it uses for the dopamine ligands, but that scan is not available in India, but we have a different drug, which is a technician-based drug, which is called as a TRODAT, which is almost equivalent to the DAT scan, and so that can identify Parkinson's disease patients. Sometimes other Parkinsonian syndrome, which we call it as Parkinson plus syndrome, which means that they have patients who have both the typical features and they also have other areas of the brain involved, like cerebellum or the cortex, which are called as Parkinson plus syndrome, can also have an abnormality on the F-TOPA and the TRODAT scan. So for them, it may be useful to use an FDG PET scan, which can differentiate between Parkinson's disease and Parkinson plus syndrome. So what exactly happens, or just a very, very simplistic manner of how we would identify the Parkinson's disease is that this is the normal pathway which you have. So we can see that The red ones are all the stimulatory pathways and the blue ones are all inhibitory pathways. So in patients with Parkinson's disease, the substantia nigra, that is the SNC, actually gets degenerated. So the stimulation from both the side comes down. So both the it has got both inhibitory as well as a stimulatory effect. So the inhibitory effect, the stimulatory effect is on the direct pathway, whereas the inhibitory effect is on the indirect pathway. Both of them come down. And so what happens is that the globus pallidus interna and substantia nigra pars reticulata has a very marked inhibitory activity on the thalamus. So there's an inhibition of the cortex. So because there's an inhibition of the cortex, the amount of stimulus which comes from the cortex to the brainstem and the spinal cord comes down. And so that's why you have bradykinesia. This is the model for movement reduction. So if I want to move my hand from here to here, because I have an inhibition of the thalamus on the cortex, I mean there's no stimulation from the thalamus on the cortex, so I can just move the hand from here to here. So this is what happens in Parkinson's disease. This is a very, very simplistic view, and this only deals with the bradykinesia, but it still has an idea about why we have the disease. So this is basically because of the dopamine which is released from the substantia nigra pars compacta and effects on the striatum. So what we do is we try to increase the amount of dopamine in the substantia nigra pars compacta so that the D1's pathway gets activated. So that's what the medication is all about. Search for a cure is definitely on. We've been looking for a cure for as much as we can think about, but we don't have a cure. The treatment is still symptomatic. There have been few anti-synuclein, alpha-synuclein antibodies which have been tried, which have come to around phase 2 level and phase 3 level studies, but unfortunately they have not shown benefit in the trials, and so they have been stopped. So now the treatment is still symptomatic, but we are hoping these are the drugs which have been tried, at least cinpanemab, trastuzumab, nilotinib. But unfortunately, the hopes have been shattered. So we will wait for a few other drugs to come in. So the therapy that we have, because dopamine is reduced, so we have dopamine cannot be given orally because it will just get broken down. So you have to give a precursor of dopamine. So levodopa is given, and levodopa is converted to dopamine by a drug called as dopa decarboxylase. Because we don't want to have a peripheral dopa decarboxylase, we actually give a combination of levodopa with dopa decarboxylase, which is carbidopa or benserazide, in a ratio of 1:4 or 1:10. So this is the commonest mode of therapy which is given. So usually carbidopa 75 milligram in a day will completely inhibit the dopa decarboxylase. So what are the side effects of levodopa? They have psychiatric symptoms, nausea and vomiting, hypotension, gastritis, drowsiness. If you have all seen the movie Awakenings, the effect of levodopa on Parkinson's disease patient can be that dramatic. So they can actually improve all the symptoms of Parkinson's disease. But the problem with levodopa, it's a very good drug. I mean, it's an amazing drug. It is the first miracle that has happened with Parkinson's disease. But the problem with it is that on using it for a longer time, it can cause wearing off effect. So it means that the effect of the levodopa starts to come down as the time goes off. And sometimes you can have, non-unpredictable loss. So suddenly you give the levodopa, it doesn't work. Sometimes you give the levodopa, it works. And it can lead to other motor complications such as dyskinesia. So dyskinesias are these extra movements which can happen in these patients. This is the way that they have extra movements. It is completely involuntary. They don't have an idea that the patient is having a problem. So you can see the amount of extra movements that the patient is having. So what happens is that as the disease goes by, they tend to have fluctuations between and off and these dyskinesias. So what are the other drugs that we can give? So these are some of the brand names for levodopa. So we have other medication which is called as COMT inhibitors. So when you have a patient who's got levodopa effect, but it's not lasting for more than 2 or 3 hours, you can actually add them to another drug called as COMT, which breaks down the levodopa. So you can give entacapone or opicapone, which can be given with every dose, or opicapone, which can be given once a day. So there are some more formulations which are coming up with levodopa itself. So maybe subcutaneous levodopa infusion, levodopa inhalation. So there are some nitrate formation which can bring the effect faster, but all of them have the same problems. The other drugs which can be used are dopamine agonists. They act directly on the dopamine receptor, and similar to levodopa. They can be given before levodopa, especially in youngsters, and to delay the wearing off effect and other motor complications caused by levodopa. So they've been available since 1970s. There are multiple levodopa dopamine agonists which are available. There are 2 types, ergot-derived and non-ergot-derived. We are not giving ergot derived nowadays because they cause a lot of fibrotic reaction, but the non-ergot derived dopamine agonists like ropinirole, pramipexole, rotigotine, apomorphine are commonly used. The side effects are similar to levodopa. It causes nausea, vomiting, postural hypertension, confusion, hallucination, and somnolence. As I told, the ergot causes a lot of fibrotic reaction. The non-ergot dopamine agonists have got this whole bunch of impulse control disorders, which are changes in the behavior of the patients, and these can cause a major disturbances to the patient and the patient family. So they can have pathological gambling, hypersexuality, compulsive eating or shopping, funding, excessive hobbies. And sometimes, a lot of times, the patients, all the attendants don't even know about these disorders. I think a lot of people don't know about the impulse control disorders. This, if it comes in younger patients, they are more common in younger patients with dyskinesias, and if they are this is happening, you'll have to reduce the medication and stop. 14% of patients who have dopamine agonists can have impulse control disorders. The third group of drugs is monoamine oxidase inhibitors. They are milder drugs, but they delay or reduce the breakdown of dopamine by MAO-B. They can be given in the initial period of Parkinson's disease or in the later along with levodopa. It can reduce the dosage of levodopa by around 15%. Some of them have got a possible neuroprotective effect. That's why we are looking at whether it helps. Both rasagiline and safinamide have shown that there may be some uh, protective effect, but we are still not sure about it because on the long term, probably it doesn't make so much of a difference. They reduce the disease progression by probably around 1 or 2 months. That has been the what has been seen in the trial, but apart from that, we are not sure. The side effects of levodopa can be enhanced by MAO-B inhibitors. They can cause hallucinations, confusion, constipation, lightheadedness, dry mouth, or nausea. So this was the comparison on that 1 year where you can see that if you had given rasagiline, which was delayed start, and the patients who were on rasagiline from the beginning, there was a change in the tempo of the um, progression. But again, this is still yet to be proven. COMT, as I told, are given along with levodopa. They have no entry into the brain. They actually work only in the periphery. So they increase the half-life of levodopa by reducing the degradation of the levodopa in the blood. So they have multiple drugs are there. By itself, they don't cause so much of additional benefit to the patient, but they change the time of action of the levodopa. Now there are multiple other drug groups. Like so, we in India we have dopaminergic inhibition and cholinergic excitation. So we use a lot of anticholinergics because they're cheap and they've been available for a long time. So like trihexyphenidyl, which is commonly used, can be given. So improve tremor and stiffness. They're very cheap compared to the rest of the medication. But the problem is that they cause a lot of side effects like dry mouth, blurred eyes, constipation, urinary retention, and major problem is cognitive problems on continued usage. So in the West, it has almost been stopped. India is still continuing to go on, but I think a lot of doctors are stopping to use the anticholinergic. Amantadine is an antiviral drug which has got an anti-glutamatergic effect and also a bit of anticholinergic effect. So this is one of the drugs which is used for reducing dyskinesia. So the patient develops dyskinesia, so you can start on amantadine. So if you look at what is the net reduction in the off time, you can see that it's not very significant. The off time means the period where the patient is not able to walk at all, and the on time is when they have a response with the medication. So if you see that it actually lasts from around 0.7 hours to around 2 hours, this is, 3 hours or 4 hours is the on time of levodopa, carbidopa. So if you look at all the other dopamine agonists or the MAO-B inhibitors, it is not so much. Now, what are the other drugs which are used for non-motor symptoms? The non-motor symptoms are, again, there are a huge group of drugs which can be used for, and it has to be individualized. As I told, they can be because of serotonergic or noradrenergic or adrenergic involvement. So if you have anxiety or depression, you can give SSRI. If you have autonomic disturbance, you can give midodrine. Urinary disturbances, mirabegron is commonly used. Constipation can be treated with laxatives. So each and every patient has to be discussed about all of the symptoms, and the treatment has to be individualized to each patient. Cognitive impairment, you can give anticholinergic inhibitors, which may also improve the gait. You have non-pharmacological therapies, which are definitely very important, especially with the World Parkinson's Day. I think that's what is important, is that you need a holistic approach for Parkinson's disease patients. So occupational, physical, speech therapy, Yoga therapy, music, dance therapy, nutritional interventions can all help in the treatment of Parkinson's disease. So, how does the progression of Parkinson's disease go on? So, this is the 4 years where there's a good year. So, this is the on and off. You can see the fluctuation, and then 4 to 7 years you have the on off period comes down, and beyond 7 to 10 years the dyskinesias become more, and beyond 10 years the therapeutic window depends. So if you look at, so the initial 0 to 4 years is where the patient improves dramatically with the oral medication, and then you have a lot of fluctuation, dyskinesias, psychosis, non-motor symptoms can become very prominent. So when you have an advanced PD with predictable or unpredictable waning of response, we call it as that we think that this is the period when they require continuous dopaminergic stimulation. So there's a Delphi consensus done by a lot of experts all around the world where they have used this 5 to 1 paradigm. That is that they're using 5 tablets of levodopa and still have 2 hours of off and 1 hour of dyskinesia. They need continuous dopaminergic stimulation. The three modalities of continuous dopaminergic stimulation which are available today, that is the levodopa infusion, apomorphine, and deep brain stimulation. All the therapies are quite effective in improving motor symptoms in patients with PD, including dyskinesias and motor fluctuations. But there are a lot of changes when you come in non-motor symptoms. So if you have cognitive impairment, it may be better to go for levodopa pump. If you have a lot of sleep disturbances, mood disturbances, apomorphine might be a good option. If you have a urinary symptoms, fatigue, and again sleep disturbances, ST and DBS may have a improvement. So the non-motor symptoms and the age of the patient, all of them will determine what kind of continuous dopaminergic stimulation that patient wants to use. In India, we only have apomorphine as well as the DBS, which is DBS was the first to start. Apomorphine has just been available for the last 3 4 years. It's only available as a pen or infusion, certain areas. The levodopa carbidopa gel is not available as of now directly in India. You have to import it from UK and it's very expensive. So only those few who can get it imported can actually use it. Hopefully the availability will become better in the future. Our initial response with subcutaneous apomorphine is quite good. Apomorphine is the dopamine agonist, just like ropinirole, pramipexole, or roticotin, but it acts on both dopa1 and dopa2 class of receptors, whereas the ropinirole, pramipexole, or roticotin acts on more on D2, so they have more chances of ICD, whereas apomorphine doesn't have so much of effect on the impulse control disorder. It also can cause impulse control disorders, but to little lesser extent. It is the oral bioavailability is only 4%, so we have to give subcutaneous infusion, and it is the only drug with efficacy which is compared to that of the levodopa. Apomorphine can be given as pen or pumps. So pen is like just you give a shot. I'm sure a lot of people might have seen these videos where the patient you can see is stiff. That's Dr. Vinod Mitra there. And you can see the patient with the apomorphine. Now, I want to tell you that this is the same kind of response you get with levodopa. When we do a levodopa challenge also, we get the same response. So you have a patient who is off and then you have a patient who is on with the medication. So but with the apomorphine, the advantage is that it comes in within half an hour, but the effect lasts only for 1 to 2 hours. If you give a pump infusion, then you can, it's a outside pump, you can actually continue the medication for almost 16 hours. So you remain in the on state and you don't have these fluctuations of on and off. If you look at the second line of therapy, which is available here in India, is the deep brain stimulation. It is useful for patients in more than 5 years. This has been available in India from 2000, and our center has done more than 700 odd patients with Parkinson's disease have undergone deep brain stimulation. This is done in advanced stage PD patients with at least 5 years disease duration. So you have a patient who's got that 5 to 1 criteria, you can go for DBS. There are some features which are for DBS and against DBS. If you have young age, you have got good levodopa response, then you should go for DBS. DBS is a brain pacemaker which can be done. So I'll just show you the video of post DBS. This is a patient who underwent DBS almost 20 years before, and this is a very good response for a patient who's got that. And this is one patient who's got undergone DBS 2 years before, and you can see him that he's completely good. So these are patients who were not so great before the DBS. No, again, we don't do surgery for patients who don't respond to levodopa. The on state, that is the response to levodopa when it is there, it is almost equivalent to what you get with DBS or apomorphine. But the point is that you don't have fluctuation, so you don't have an off period. So you don't go up and down, you just stay steady. So when you have a patient with on medical management, what happens is that they are so restricted because they are worried that they'll go off, that they stop moving or stop doing their activities. The other thing is that once the dyskinesia start, they have to reduce the amount of medication so they don't completely become normal. If you look at the DBS, we've seen patients who have had DBS after a decade and seen the functional outcome, they all do very well. Non-motor symptoms are center. We found that there's a significant reduction in the non-motor symptoms. There are limitations. So if you look at age of the patient, we normally don't do DBS in a elderly individual more than 75 years. Higher prevalence because they have higher prevalence of cognitive impairment and posture instability and falls. If you have genetic factors like GBA mutation carriers, these patients don't do so well after DBS. So these are some of the problems which can happen. If you have axial symptoms, you don't do DBS so often. But then again, if you develop these after the surgery, you can tweak it, you can change the stimulation parameters. Right now, there are so many newer modalities which are coming, like directional leads and MICC, where you can steer the current around and check for it. There are surgical complication and DBS failures. We may have to redo the surgery. Sometimes you have infection and hemorrhages. But in spite of that, DBS actually offers quite good response. If you look at the DBS center, these are the centers, much more than the apomorphine centers. But I think apomorphine and will also start up. Looking at the cost effectiveness, DBS costs probably around 10 lakhs for a period of 5 years, or maybe around 15 lakhs for a period of 15 years. So that's around 1 to 2 lakhs per year. Apomorphine costs around 3 lakhs per year, currently available. Levodopa pump actually costs around 12 lakhs per year. So I think that is the reason why the DBS is much more prevalent as an advanced therapeutic option in India. Other potential newer therapies, we have got levodopa carbidopa intestinal gel, versus there is a subcutaneous levodopa which has come up, which is will probably be marketed. This is still in trial, but it's similar to the intestinal gel. There's sublingual apomorphine, which probably may be useful. And to conclude, drug refractory offs, and the conclusion is that the PD is a complicated disease, but you need to individualize each and every patient and make sure that they have their symptoms are satisfied. So it is not a single treatment option which will fit all of them, but you need to think about what causes what problems and then treat them accordingly. Thank you for your patient listening.